Next presenter, Dr. Nimisha, Assistant Professor, Department of General Surgery, Government Medical College, Thrissur.
Excuse me, ഫ്രണ്ടിലേക്ക് മാത്രമേ പോകുള്ളൂ. ശരി, സ്റ്റാർട്ട് ചെയ്തു.
Welcome, Dr. Nimisha. She was very active and enthusiastic PG during the PG days in Calicut. Okay, proceed.
Respected chairpersons, eminent teachers among the audience, my dearest colleagues and friends, at the outset, let me thank the organizers for such a wonderful conference and giving me the opportunity to stand before such an august audience, and for my dear Gobi sir for such warm words of welcome. So today's topic allotted to me is the basics of postoperative fluid management. It's an exhaustive topic, so I am sticking to the very basics, the very basics. So if you ask someone what is the treatment of tuberculosis, you will say ATT. If you ask someone what is the treatment of acute appendicitis, you will go for emergency appendicectomy. But fluids, though it is so common, you don't have a prescription for that for every single patient. You have to custom make the fluid prescription for a patient each and every single day. So I'll be going through the basic physiology, running through the topics rapidly. Then we will think about the properly what fluid, when to administer, how much should be given. A word about additives to the fluids, and some special situations will be rushed through if we have time. So basically, the surgery that we subject the patient to is a big stress, and this causes an adrenaline surge. The renin-aldosterone angiotensin axis is activated. There is a lot of ADH being secreted, which causes salt and water retention. At the same time, the brain, the cerebral metabolism is dependent upon glucose. It requires at least 100 grams per day. So you have to supplement that no matter what. And we should remember that the inflammatory response is proportionate to the surgical insult. The greater the surgical insult, the greater the response. So how do the fluids behave within the body? We know there are crystalloids, we know there are colloids. The crystalloids, most commonly used ones are the normal saline, which contains actually more sodium and chloride than the human plasma. So it is neither normal nor physiological. The ringalactate and other balanced salt solutions, they are mostly slightly hypotonic. The dextrose, basically it is metabolized by the cells and breaks down into carbon dioxide and water. So you will think that metabolism takes some time, but actually it doesn't. Within 15 minutes, 1 liter of dextrose, 5% dextrose that you are given is broken down into 250 ml remaining water, and the rest is going out as carbon dioxide and urine. So that is the situation of crystalloids. What happens with the colloids? Now the albumin, if you give it for hypoalbuminemia, you will have to give about 500 ml to raise the serum albumin by 1 gram. And even if you say that 100 ml of albumin infused will raise the intravascular volume by 100 ml, actually only 80 ml rise will happen. And the other colloids, dextran and hetastat, has their own problems, though dextran can have some extra special uses. So in this scenario, we should remember that preoperatively, most of the patients are in negative fluid balance. Intraoperatively, the anesthetist balances it for us using warm ringalactate, blood as well as blood products depending on the surgery. Postoperatively, we decide, and most of the time it is the junior most surgeon who writes out this prescription. So it is imperative that you understand why, what and how you write. So the first thing you have to think about your patient is whether you need fluids. Now if you decide that you need fluid, how much should you give and what fluid should you give? And after you are writing the prescriptions, every day you should reassess whether you can stop or whether you should escalate. So do you need an intravenous fluid? Even if you give the nectar of life, no patient will want it through an intravenous drip. Everybody will be happy having their thalamies. So if the patient is conscious, if they have a competent GIT and if they are euvolemic, there is no point giving fluids. So if you decide that you have to give fluids, what fluid will you give? If you are intending a nutritional supplement, you have got a lot of nutritional fluids. If the patient is having a transfusion trigger, for the normal person it is supposed to be 7 and for the elderly we keep it at 8, but our anesthesia colleagues and even we ourselves transfuse earlier. So that is regarding blood and blood products. Then the colloids, already I have mentioned that there are a lot of problems with that. So that leaves us with crystalloids as the first choice for the immediate postoperative period. So how much fluid should we give? The NICE guideline says that we should think about the 4 hours plus the additional 5th hour when we think about how much fluid we should give. We should give the routine maintenance fluids. We should replace what is lost by the patient. We should give extra fluids if you are planning to resuscitate the patient. And if there is redistribution as in pancreatitis, extensive surgical resections or in burns and all, then you have to consider for that as well. Now every time you have to reassess and see whether the patient's requirements vary. How do you give maintenance fluids? It should be given according to the ideal body weight of the patient. So maximum of 1500 to 2500 ml alone is required in 24 hours time. So that will come to around 1 to 1.2 ml per kilogram per hour, and sodium you will need only up to 50 to 100 milliequivalents in 24 hours of time. So in the first 24 hours usually you don't need to supplement sodium, and potassium also you don't have to supplement in the next in the first 24 hours because the tissue trauma releases a lot of potassium from inside the cells. So the fluids that we are left behind is 5% dextrose, and then we have something known as plasma light, 0.18% saline with 4% dextrose, but is usually not used in our setups. Now coming to the replacement, how do you replace? You are supposed to replace like with like. So if you lose blood, you have to give blood and blood products. If it is a third space loss, that is the only role for colloid plus crystalloid. So there is no way you can give just colloids for a patient. If there is GI loss, you can give either ringalactate or you can use normal saline added with potassium. And these should be critically monitored according to the mental state assessment, serum lactate levels and the hemodynamic trends. How do you resuscitate? You resuscitate when you have a hemorrhage or when there is vasodilatation due to acute sepsis. So after giving all these fluids, you are reassessing and you are thinking, should I stop? Can I stop? Will I stop? So you should stop whenever it is possible to stop. So if the patient is conscious with a protected airway and there is a functioning alimentary tract, you have to stop. You have to monitor the patient, look for edema, auscultate for pulmonary edema, maintain the CVP so that the mean arterial pressure is above 65 mm of mercury. But remember that when there is head injury, brain trauma, you have to keep it above 90 mm of mercury. Tachycardia is a poor pointer towards fluid deficit. Now in the first postoperative day, we come across a lot of patients having decreased urine output. So always think about other causes, including catheter block and raised abdominal pressure. Intra-abdominal hypertension is one cause that you should keep in mind. You add a lot of things to your fluids. You add insulin, potassium, inotropes, a lot of things. Now when you add insulin, remember that 10 to 15 grams of carbohydrates can be metabolized by a single unit of insulin. So if your blood sugar, if your dextrose is just 1 unit of dextrose, which contains 5 grams in 5% dextrose 1 liter, you need to add only up to 2 units of insulin to metabolize it. So it's always a good practice to add up to 6 to 10 units according to the insulin resistance of the patient. Potassium and calcium, be careful when you are giving such things as infusions because it can cause cardiac arrest if you are giving rapid infusions. Now the other additives are according to the need of the patients in trauma and long-term nutrition. So are there any substitutes? There are no substitutes, but there are ways in which we can reduce IV fluids pre-operatively, intraoperatively and post-operatively. If you reduce the fasting, if you reduce the incidence of bowel preparation, if you give a preoperative carbohydrate loading, that will go a long way in reducing IV fluids. Intraoperatively, if you have an invasive monitoring, you can go for early goal-directed therapy. Postoperatively, institute the enteral nutrition, even if it is a feeding jejunostomy or the right tube across the anastomosis. Now, if you have a stoma, remember that you need more replacement fluids, and if it is burns or pancreatitis patient, they will have increased requirements. Now, one word of caution, free tissue flap surgery, they have a blood vessel anastomosed, but they don't have lymphatics anastomosed. So, if you push in a lot of fluids, your flap will swell up and your reconstruction will break down. So, reduce the crystalloids. In all intrathoracic procedures, lungs do not like to be wet. So, restrict the IV fluids. Liver resection patients, reduce the CVP to maintain in and around 5 centimeters of mercury so that blood loss is reduced. So, the elderly pediatric patients, they don't tolerate fluid imbalance well. The malnourished, you should always be worried about refeeding syndrome. The cardiac, hepatic and renal disease patients are always overloaded with sodium and fluids. So, their IV fluid prescription should be restricted. Hypertension and adrenal tumor patients, they will have volume contraction. So, we should always be careful when we give them fluids. These are the recent studies which basically say that it is better to give crystalloids rather than colloids, and among the crystalloids, the lactated ringer solutions and other balanced salt solutions have an advantage over the normal saline. This is one paper I came across which is very sensible. Please go back and read if you can. And this is the take home message that I would like to impart. If it is a less than 4-hour surgery, if you can go back in the evening and can start orals, then give only 1000 ml of 5% dextrose at 75 to 100 ml per hour. So, when you go back in the evening at 6 p.m., you will see that the patient is fully conscious and can eat food. They would have received only 400 ml of fluids. That's enough. Stop the fluids. Now, the surgery is more than 4 hours or you cannot start the orals in the evening for whatever be the reason, then you will have to give up to 2000 ml of fluids, and always remember to write the infusion rates. From the next day onwards, you will have to add what is deficient according to the lab reports. Now, remember that like should be replaced with like when you have drains and stomas and GI losses like that, and you should remember that the additives should be according to the lab reports. Now, 25% dextrose should be added 6th hourly from the second day onwards, but if beyond 3 days, if you want to maintain IV fluids and IV support, you have to add the nutritive therapy in the form of TPN. These are my references in addition to the standard textbooks of Sebastian, Bailey and Schwartz, along with the papers. All queries are welcome.
So, Nimisha, it was a nice presentation because although we are very late, but it's a very relevant topic. Latest So, this topic, because it is very important because we all deal with this, from the junior most PG to the HOD deal with it. But sometimes we forget to instruct the juniors. We don't spend that much money, that much time to correct it. So many pitfalls are there. Your speech was an eye-opener for all of us. Very good. Nice work. Any, sir? Soman, sir, please.
Nimisha, she was my final year student and also PG student. Nice to see you there. My question is, after surgery or any stress, the human body retains sodium. So, is there any rationale in giving lot of normal saline after surgery?
Thank you so much, sir, for that question. Actually, that is one point that has to be stressed because there is no role for sodium chloride infusions immediately after surgery because humans are supposed to have evolved from the African forests. So, we have immense capacity to concentrate sodium and water, to conserve it, but we cannot excrete it. So, after the surgical stress, when the sodium and water is retained due to the stress response, we should be careful that we don't add on to the insult by giving NaCl. So, there is no role for the saline infusions in the immediate postoperative orders.
but we routinely give in order to, fearing that patient might develop hypertension during postoperative period.
Exactly, sir. So we have to
Otherwise,
reassess.
otherwise there is no role for any sodium chloride during the postoperative period.
Exactly, sir. So only if we have replacement or any ongoing losses, we have to give that NS. Otherwise, there is no rule.
Questions? Enough time, you can ask questions. Otherwise, we'll conclude. Thank you, Nimisha, for a wonderful
Thank you
presentation.
very much. Thank you very much, ma'am.
Thank you so
I
much, sir.
request Dr. Nimisha to kindly stay on the stage.